Hello, our subject today is about obturation of the cleaned and shaped root canal system. We will discuss first, is obturation important and which thing is more important, the obturation or the cleaning? There is a study that was made on an animal tooth where the group of teeth were cleaned and shaped without any obturation, and another group, after the shaping, they were obtured with Gutta-percha and resin-based sealer. After 190 days, there was no difference in the healing between the instrumented and obtured teeth and the instrumented and unobtured teeth. To this date, there is no effective method for determining whether cleaning and shaping procedures have been effective. What the author is trying to say, that cleaning and shaping is more important than the obturation. Until now, we did not reach to a method to clean and shape the canal 100%, which means that the goal of obturation is to seal this area of infection that has a minimum amount of bacteria, to seal from reaching the periapical area, which means that the apical seal is so important to get the healing we are aiming for, and to keep the remained bacteria sealed in its place, which is the canal. Also, the coronal seal is so important to prevent any leakage that may reach the apical area. Until now, we do not have any method that can determine the efficiency of the cleaning and shaping, but the obturation is actually a reflection of the cleaning and shaping, which means it evaluates if the length that it evaluates the length, the taper, and the density. It reflects if the canal is cleaned and shaped well before, which means good obturation is a reflection to a good cleaning and shaping. Now let's answer a question. Do we have to retreat a tooth that has been treated endodontically for 3 months without that did not get a permanent restoration? The answer is no. If you do not have symptoms and any radiolucency around the tooth, we should not retreat the tooth after 3 months if it did not have any permanent restoration. For example, because the reason is what we said earlier, that the methods until now are not certain, so we cannot rely on something uncertain. For example, let's say this case, we can say that the tooth is obtured well, reaching the full length, but when we took an angled view, we can see the voids. Now, do you think that this case need a retreatment? The answer is depending on the time of doing the obturation. If it was more than 3 months, and this apical, which means that this apical radiolucency is old, retreatment is indicated. But if the treatment was less than 3 months, and this lesion is maybe in the phase of healing, so we wait and see the progress. If it was healing, so a permanent restoration can be applied. I mean like a full coverage crown. Now let's discuss the rate of healing of the tooth depending on its situation before the its initial situation before the treatment. In a study of root canal treatment tooth for 4 to 6 years, they found that the pre-existing apical periodontitis were found to have a lower healing rate, 82%, compared with teeth without a periapical radiolucency, which its success rate was 93. Also, the adequate length had a healing rate of 87%. The inadequate length was 77%. Also, the vertical compaction increases the success rate to reach 90%. So the goal of obturation to get the higher success rate possible is avoid free-filling material and a correct length. Here the author is discussing the concept of a one visit versus multi-visit treatment, endo treatment. He's saying that if the pulp was vital and we have a normal pulpitis, one visit obturation is recommended, and in fact it is it decreases the contamination that may happen of the coronal leakage during the period between patient visited, so it is recommended. As for the necrotic pulp tissue, if the tooth was asymptomatic and we have asymptomatic apical periodontitis or chronic apical abscess, it can be treated in one visit. But when the patient has an acute symptoms caused by pulp necrosis and the acute periradicular abscess, obturation is generally delayed until the patient is asymptomatic. So the managing the symptoms is important, and we should delay the obturation until everything is under the control. What about using calcium hydroxide as a medication between intracanal medication between the appointments? They're saying there are so many studies that are contradicted about this such situation. Some are saying that the effectiveness is comparable to the mechanical cleaning of instrumentation and using hypochlorite. So it does not really affect on the result and increases the bacterial elimination. As for other studies, they are saying that it is a good medication, intracanal medication, if you are not doing the treatment in one visit. So why not putting it to make sure that the canal is clean during the sessions. But however, the cleaning of the calcium hydroxide is a bit challenging, and it may interfere with the obturation sealer and make the obturation not so sufficient or good. So a result, in general, obturation can be performed after cleaning and shaming procedures when the root canal can be dried and the patient is not experiencing significant pain and swelling. So the obturation cannot be done if the canal is not dried. However, some doctors are suggesting that MTA is hydrophilic and it can maintain some moisture in the canal. So, but this the long-term success of these situations is not really studied yet. Also, we must take in perspective the medical conditions and the psychological condition of the patient, the fatigue rate, which may need multiple short appointments. Now let's talk about the length of obturation. When do we should stop the obturation? We must know three things. The apex locator mechanism of working is that the voltage or the resistance of the dentino-cemental junction is the same as the mucosa. So when the file reaches this the dentino-cemental junction that is located in the apical area, the current flows and the circuit is closed. So this the apex locator is actually telling us that the file has reached the area beyond the apex of the tooth. But we know that by age, the dentino-cemental junction varies, which means due to the additional growth of the cemental inside the apical area. So we cannot only rely on the apex locator, and taking radiograph in association with the apex gives the highest rate of accuracy. We can see here this is called the apical constriction. It is the place where the obturation must be stopped. It is far from the foramen, the apical foramen, between half or 1 millimeter. Stopping the obturation in this area has given the best results in the healing process. What do you think is more harmful to the periapical tissues? The extrusion, which means the extrusion of the material, or short obturation. Actually, long obturation has given a lower rate that reaches 20% decrease of the success rate of the obturation. So we must always should not extend beyond the apical foramen. This is a rule. How do we prepare the dentinal wall for the obturation? Is by removing the smear layer. This smear layer happens due the organic or inorganic material when we are doing the cleaning and shaping. So when we apply EDTA for 1 to 2 minutes, we can see that it is settles the surface and opens the odontoblast tubules. Then we use, as a final rinse, we use sodium hypochlorite activated for 1 to 2 minutes also to get a clean surface that is ready for the obturation. Before the obturation, we must dry the canal with the paper points, and we know that we should not between the EDTA and sodium hypochlorite, we should use the water saline to prevent any precipitation that may form due to the combination of both of them. Now let's discuss the obturation materials. The most important one, or the most famous one of them all, is the zinc oxide and eugenol. We know that it has an antimicrobial effect, but it has the solubility effect, and it shrinks after setting. But in the long term, it has given a high rate of periapical healing, and it has been used for actually a long time. The calcium hydroxide sealers, the reason why they added calcium hydroxide to the zinc oxide is to exhibit an antimicrobial activity, but it did not give good results because this antimicrobial activity is only initiated when the calcium hydroxide is is mixed with a soluble, which means that the solubility is important for the antimicrobial activity. And we know that the rule of obturation is a dried canal, so it did not give the results that was aimed for. The steel apex is a famous commercial name for this kind of sealer. The glass ionomer sealer has a bonding effect to the canal walls, but it needs conditioning agents to receive the glass ionomer sealer, and it was difficult to do the conditioning in the apical area, so it did not also give the results that it was aimed for, and it has a minimal antimicrobial activity. Also, for the retreatment, it was hard to remove this kind of sealer. The resin sealers, we have the epoxy resin sealers, the AH26 and the AH+, which are close in their effect. They come in a base and catalyst tubes that are mixed and applied. And now we will discuss the term monoblock, which refers to the idealized scenario in which the canal space becomes perfectly filled with a gap-free solid mass that consists of different materials and interfaces with the advantages of simultaneously improving the seal and fracture resistance of an obtured root canal treatment. When the etchant and the primer and the sealer were all combined to the on self-etching or the self-adhesive sealer, it was advantages in that it reduces the application time as well as errors that may occur during each bonding step. The MetaSeal is the first commercially available fourth generation self-adhesive dual curable seal. It binds to the radicular dentin, and it also binds to the root filling material, the thermoplastic material. The silicone sealers are actually, it consists of a Gutta-percha in a particulate form less than 30 micron, and it is added to in capsules injected with this injection syringe. It provides a working time of 15 minutes and sets after 30 minutes. Earlier, the biocompatible material were added to initiate cementoplastic formation to increase the healing of the periodontitis and chronic abscess. Now let's discuss the MTA or the tri-dicalcium silicate sealers. They are biocompatible. They have antimicrobial effect. They are hydrophilic. They like moisture. They come in a powder. When it mixed to water, the rigid it's the reaction starts consisting of a rigid matrix. These hydrates forms on the surface of the original calcium silicate particles, and hydration gradually penetrates inwards. That is the reason why the setting time of the MTA takes up to 6 hours, because this process takes time and it happens gradually. We have the bio route, the eye route, which is injectable, and a single MTA syringe, which means it does not need any combination or process or something. Here are the products and their manufacturers, the composition, if anybody is interested. The Bio C, the T Plus. Some differ in the shape. Some of them are combined in a mixing tip, powder and gels. MTA will be discussed more when we talk about the periradicular surgery. Here the author is forbidding the use of formaldehyde in an endodontic treatment because of its high toxicity, that if it reaches the periradicular area, it can use a neural damage. Here it initiated an reaction, build reaction. For the placement of the sealer, it can be with a lentulo spiral, or masticone, a file, or ultrasonics. That it was reported that ultrasonic produced the best sealer distribution when used, but there was no significant differences in the techniques after obturation. The Gutta-percha is the most popular core material used for obturation because of its plasticity, ease of manipulation, minimal toxicity, radiopacity, and ease of removal with heat or solvents. Its disadvantages includes its lack of adhesion to dentin and shrinkage upon cooling. Also, it is mainly made of natural rubber by 20% and 65% of zinc oxide, 10% of radiopacifers, and 5% of plasticizers. It comes in different tapers to compensate with the canal shapes and the preparation and the preparation size equipment. We can do a custom 𝐏𝐻𝐿𝐴 by um, to fit different different canal shape. We can do it by heat and two glass spatula or two glass slabs by rolling it after heating it, or we can soften it with the chloroform and combine it with more Gutta-percha to get the shape and thickness we want. Now let's discuss the methods of obturation. The lateral compaction is actually the one with what we were trained in the uni, that we use the master cone inserted into the canal, and when we feel the tug bank in the apical area, we remove it. Then we insert the sealer all over the canal walls. Then we put sealer on the master cone and reinsert it. Then we use a spreader that is smaller in size than the master cone and do the compaction. Then we add accessory additional Gutta-percha, and we do additional lateral condensation with smaller spreaders until we finish the canals. We can do each canal by itself, or we can insert the master cone in each canal. Then we add the additional ones if the tooth location is far, or it was not accessible in seeing it easily. What about the lateral condensation? Lateral condensation has two techniques. The first one is that the master cone is inserted half to 2 millimeters up the apical constriction. After that, a heated blocker is inserted and the coronal part is trimmed. Then a non-heated blocker is inserted to compact the Gutta-percha and to create a seal in the apical area. Then we add another cone and we repeat the steps by cutting and blockering the middle part and the coronal part until we get the seal all over the canal. This is the obtura. System B. This is the system B that we cut the canal using this heated tips, and this is the blogger that the size is similar to the Gutta-percha cones. The second technique is called the continuous wave compaction technique, that starts up by doing the apical seal as in the same manner that we discussed before, but to fill the rest of the root canal, we fill it with something called the backfill, which is a warmed Gutta-percha that is injected inside the canal until we reach the coronal part. This is the obtura that we inject the Gutta-percha. These are the Gutta-percha cones inside, and it is heated. Then we fill the canal. The ultrafill on the contrary, has a separate heating unit, and this injecting unit is a mechanical that only injects the material that is heated in the separate heater. For the obtura, it has something good, that it does not give heat until it is inside the canal, which prevents any accident of burning of the soft tissues. This type of the obtura system has gave the highest healing rate in reaching 97%. Let's talk about the carrier-based Gutta-percha, the Thermafil, which is a plastic core that is covered with Gutta-percha, and it is heated in this device, then inserted to the tooth to get the compaction, and it actually can fill the accessory canals with this method. It is an easy process. We can have some difficulty in the retreatment, but they made a groove along its length to provide a potential access point for placement of a file to remove the carrier, and it can be softened by chloroform and removed by headstone files. Also, these special tips or instruments can help in the removal of these cores or the plastic carriers. It has sizes 20 to 40. These are different methods if somebody is interested. After we finish the obturation of the canal, we must seal the pulp chamber, which is the coronal part, the orifice, if we are doing the restoration at the same appointment, we use the flowable composites after doing the etching and the primering. If you are not doing it in another appointment, we can use the temporary filling material like the cavet or the super EBA. That's it. Obturation is a reflection of the cleaning and shaping, and is evaluated on the basis of length, taper, density, level of Gutta-percha obturation. Obturation of the radicular space is necessary to minimize coronal leakage from the oral environment. Obturation reduces coronal leakage and bacteria contamination, seals the apex from the periapical tissue fluids, and entombs the remaining irritants in the canal. Short obturation up to 2 mm gives healing rates, but extending the obturation beyond apex has been a great reason for decreasing success rate. Apex locator and radiograph images are best ways to determine obturation length. At present, the consequence is that one-step treatment procedures are acceptable when the patient exhibits a completely or partially vital pulp. Asymptomatic apical periodontitis, chronic apical abscess, or condensing osteitis may be treated in one visit based on the best available information. When patients present with acute symptoms caused by pulp necrosis and acute periradicular abscess, obturation is generally delayed until the patient is asymptomatic. Although there are clinical traces to support the use of calcium hydroxide or alternative interappointment dressings, They do not reduce microbes beyond level already achieved by canal preparation with chlor with hypochlorite sodium. It is fair to say that inter-appointment antimicrobial dressings are fairly well accepted by clinicians in cases that cannot be treated in a single visit. Types of sealers, the zinc oxide and eugenol, will resorb if extruded into the periradicular tissues. They exhibit a slow setting time, shrinkage on setting, solubility, and they can stain tooth structure. An advantage to this sealer group is antimicrobial activity. The glass ionomer enables adhesion between the material and the canal walls. However, it is difficult to properly treat the dentinal walls in the apical and middle thirds with conditioning agents to receive the glass ionomer sealer. A disadvantage of glass ionomers is that they are more difficult to remove if retreatment is required. All-in-one self-etching self-adhesive sealer is advantageous in that it reduces the application time as well as errors that may occur during each bonding step. Bioactive root canal sealer hydrophilic 3 hours for initial set and less than 6 hours for the final set. This is talking about the MTA. The worm vertical compaction. When clinician begins obturing the root canal system by inserting the master cone to the mass is firmly lodged in the apical portion of the canal. A hot plugger is introduced, searing the point of approximately 4 to 5 mm from the apex. Light vertical compaction is applied to restore the integrity of the apical block of the Gutta-percha. The remainder of the canal is then filled with thermoplasticized Gutta-percha injected with Thermafil gun.